Welcome. We are pleased you're able to join us this evening for a special event sponsored by the UCLA School of Nursing Council on Diversity, Equity, and Inclusion and the Office of Development and Alumni Relations. I am Dr. Deborah Koniak-Griffin, Associate Dean of Diversity, Equity, and Inclusion in the UCLA School of Nursing. Tonight, we will hear from 4 alumni who have kindly agreed to share their experiences related to health disparities and COVID-19. The coronavirus pandemic has made us more aware, the public more aware, of the racial health inequities inflicted upon Black, Brown, and other marginalized communities across the country. We have become more aware of how structural racism and existing policies create social and economic conditions that lead to health disparities, which adversely influence health outcomes and life expectancy. Nurses are in the position to combat and help to dismantle racism and discrimination. The stories presented tonight by our alumni will address these issues. I have a few housekeeping notes before I introduce Dean Linda Sarna, who has welcoming remarks. Tonight's panel will be recorded on Zoom. Our intent is to upload the event to the School of Nursing's YouTube channel so that others may watch this film at a later time. If you have any questions for our speakers, please submit them to the question and answer box. At the end of the Zoom event, we will have a brief survey for you to complete. We'd appreciate you taking 30 seconds to complete this survey, as it will help us to enhance future Zoom programs. It is now my pleasure to introduce Dr. Linda Sarna, who is Dean, Distinguished Professor, and Lulu Hasselblad Chair of the School of Nursing.
Hello, everyone. I hope that you and your loved ones are doing well during this extraordinary time. When the School of Nursing was required to assume remote operations when the COVID-19 pandemic hit Los Angeles and UCLA in March 2020, we needed to find other ways to promote scholarly discussion. In fact, more people signed up for this virtual seminar tonight than we could fit in our auditorium in the School of Nursing. No topic is more important than this program on the intersection between health disparities and COVID-19. I want to thank Deborah, Anita, Craig, and the Council of Diversity, Equity, and Inclusion for their efforts in creating this forum. I am looking forward to hearing the discussion and especially to hearing from our alumni in action. I hope you enjoy the event. Let the show begin. Take care.
Thank you, Dean Sarna. It is now my pleasure to introduce Dr. Skrine-Jeffers, who is an assistant professor in the School of Nursing and also an affiliate faculty and associate director of the Arts Center for the Study of Racism, Social Justice, and Health at UCLA. Dr. Jeffers is a 2-time Bruin, having earned her master's degree in nursing in our master's entry clinical nurse program and a PhD in nursing as well at the school. She completed a postdoctoral fellowship at the National Clinicians Scholars Program at UCLA, where she gained expertise in health policy and management. Prior to this fellowship, she received several other scholarships and special trainings that I do not have time to present tonight. Dr. Jeffers' research focuses upon the complex relationship between structural barriers, including laws, policy, structural racism, and cardiometabolic and mental health of African Americans. She aims to develop community-partnered interventions to protect against structural barriers and support health equity. Welcome, Dr. Jeffers. We're so pleased that you took the time to speak with us tonight.
Thank you for having me. So if we can pull up the slides. As Dr. Koniak-Griffin mentioned, the disproportionate impact of COVID-19 on people of color has again been highlighted, has highlighted the health disparities and inequities in the US. As a historical overview of health disparities, particularly among Black people, I want to point to the next slide, which is Dr. Shanita Sealy Jefferson's figure, which shows the 400-year history of African Americans in the US. When talking about health disparities, it's important to note that context matters. For 348 of the now 401 years, Black people in America have lived within a structured system of intentional oppression and have been rendered inferior to people who are white. So 86% of the time since the first enslaved Africans arrived in this country, laws, policies, practices all reinforced one another to maintain that racial hierarchy. Next slide, please. To grasp a historical overview of health disparities in the short time we have, please consider in the yellow box assumptions of inferiority that have persisted over time. And that is that enslaved people were not ranked among sentient beings, but among things, meaning they couldn't perceive or feel things, including pain. So that justified such things as who's known as the father of gynecology now, who used to perform surgical experiments on enslaved women without anesthesia so that he could perfect procedures that he later gave to white women with anesthesia, or the justification for the Public Health Service intentionally not treating Black men who had syphilis. And then even with the publication of Unfair Treatment, this historical publication addressing health disparities, in 2016, we still had medical students note that they didn't think Black people felt the same pain that others did because they perceived our skin to be thicker. Next slide, please. All of these are important to note because health disparities are preventable differences. And they oftentimes are born out of systemic disadvantagement. And how we think and talk about disparities is often in terms of racial and ethnic differences. Next slide, please. When we emphasize racial and ethnic health disparities by comparing minoritized populations to non-Hispanic white populations, we reinforce assumptions of racial inferiority for any group that's not categorized as white, particularly if we attribute the difference to something perceived as socially deviant on its surface. And by doing that, we reinforce historical assumptions of inferiority. Next slide, please. An example is this article that recently was published, and I saw it amplified by Dr. Blackstock on Twitter, and it's entitled, "Black New Yorkers Waited 7 days on average to seek care for COVID-19. It cost them their lives." Next slide, please. It goes on to say at the beginning of the article, for white patients, the median delay was 3 days of symptoms. For Latinos and Hispanics, it was 5 days. And for African Americans, it was 7 days, or more than twice as long as whites. If you know how articles are structured in the lay media, they put all the important information at the top, and following that description, if you jump down to the second line that's underlined, it said experts at first theorized that members of these groups worked jobs that put them at greater risk, or that they were more likely to have pervasive chronic illnesses such as hypertension, diabetes, and kidney disease. Now researchers and community leaders are assessing another more nebulous cause of the disparate death rates: how long it took people to come to the hospital. Now, when you consider this fact, next slide, please, you may ask, what's wrong with Black people? Versus what happened that caused Black people to wait to go to the hospital. Next slide, please. When you recognize that there's a history behind disparities, when there's stories and experiences that are rooted in intentional structural inequity, we can think more critically about how we might other people unintentionally or not, when they wait to go to the hospital or when they don't want to be surveilled through contact tracing. We can also think more critically in our nursing practice and research and policies, particularly in comparison to groups that live different histories, socially and health-wise in the US. Next slide, please. To close, the article highlighted several reasons why Black New Yorkers waited twice as long to access care, one being of which was medical mistrust. And the writer concluded that with the healthcare system also needs to build up trust and respect from its most vulnerable patients so they can feel safe seeking help. That to me should have been the headline, as opposed to, the one that's perceived that implicates Black people in a disparity that has this deep historical roots. So I wish I had more time to go more deeply, but I do thank Dean Sarna and Dr. Koniak-Griffin and Craig and Dr. Braylock for inviting me to share a few words. And I look forward to hearing the panel. Thank you.
Thank you, Dr. Skrine-Jeffers. I think your remarks provide the perfect background for our panel to proceed. So I think that their stories will fit very well in terms of what you've already said and build upon it. So what I'm going to do next is introduce our four panelists. And I'll only say their names because in their first question, they will tell you their alumni status as well as where they're working and give you a little background on that. Each panelist will have 5 minutes to address the questions. And then you, the audience, will have time to, in the Q&A, present any questions that you may have for them. Okay, so we can actually meet now. Soraya, Setareh.
Hi.
Hi.
Thank you for inviting me to be here.
We're pleased to have you. Benjamin Cioppa. Do we have Benjamin? I don't.
Hi, thank you for having me.
Thank you. We're pleased you could join us. Jamaris Hunt.
Hi, thank you for having me. I'm here.
And Harold Sarmiento.
Hi, thanks for having me as well.
Thank you. So we will begin the alumni panel with Soraya speaking to us, and she will tell you first, her first question relates to her background and which program she graduated from at UCLA School of Nursing. So a brief description of when you graduated and your experiences as a professional nurse.
Sure. Hi, everybody. So I graduated, actually, along with Benjamin, I graduated from the MECN program in 2019 in June. And after I took the NCLEX, I actually took a little time to travel and be with my family and started at St. John's Transition into Practice program in January with the January cohort, hired as a float nurse. So as a float nurse, I rotate, I'm trained to work in a variety of units, post-critical care unit, med-surg tele, and ortho. So being a float actually provides me an opportunity to work with a wide variety of patients and adapt to different units every given day, actually. In ortho, while it's managing pain, promoting early mobility on PCCU, I'm using a lot of critical thinking and assessment. So now that I actually just started working independently without a preceptor, I'm accountable as my patient's point of care. So now I'm reviewing orders, speaking to doctors, knowing when to advocate. It's a lot. I feel like right in this very moment, I'm on a steep learning curve. I'm obviously afraid of messing up, not being fast enough, but I have to give myself grace and trust that this stuff is going to take time. And I trust that I have the qualities that can't be learned.
We understand that in your nursing practice, you became infected with COVID-19. Please tell us a little bit about this experience and how it has impacted you personally and professionally.
Okay. Yeah, I did get COVID. It was actually my first day orienting on post-critical care unit. It's actually March 23rd to be exact. I got report that this patient had, and I kept my report sheet, short of breath, fever, coughs, and chills. I had this gut feeling, and Corona was in the news, and I just felt like it sounds like that coronavirus. And I actually brought it up to my preceptor, and she's like, I said, do you think we can test this patient? And she's like, you know what, honestly, it's really unlikely. There are not enough tests to go around. And I was like, well, do you think I can get a mask? And she's like, good luck with that. You have to make friends with the charge nurse if you want a mask. So I'm like, okay, because they were hoarding masks. There's a nicer word for hoarding, but for lack of a better word, hoarding masks at this point. So I really found myself between a rock and a hard place. On one hand, I want to be this eager learner, go with the flow, new nurse. And then I wanted to trust my gut. Something felt off and I needed to speak up. And anyway, I carried on with the rest of the day, caring for the patient, came home, hugged and kissed my family. And that's an important note, that I hugged and kissed my family. 2 days later, I came back to work feeling totally off, barely able to take care of this patient, not this patient, 4 patients that I had. But I was afraid to leave. Again, I'm new, I want to be resilient. So I held it together. And then when I get home, I just completely collapsed into a heap of chills, fever, cough, you name it. So how it impacted me personally was I got scared. I got the virus that shut down the world. We're dying. My husband now gets it from me. I have to take care of our kids. We live in a tiny apartment. It was just a really scary time. Professionally, it's really hard to say. I'm kind of still in the throes of how it's impacted me professionally. I actually had to take a 4-month leave. So that set me back in terms of my training. I also had to go on workers' comp, which unbeknownst to me is a lawsuit, although not a contentious lawsuit, it's still considered a lawsuit. So the hospital was not getting in touch with me. I'm isolated, I'm not getting communicated from the hospital. And this whole feeling was just, something was not a good way to start my career in nursing, let's just put it that way. But now that I'm back, I'll be honest, I'm still a little nervous caring for COVID patients. I was a little bit skittish, but it's also a gift to me, and I get to share my success stories with my patients. I actually had a patient last week burst into tears when I told her that I was a COVID survivor, and you can be a COVID survivor too. You can be okay. I get to share my story of resilience and true empathy. Sorry, that was a long answer, but that's kind of.
So because of time, I'm just going to do one last question, and that would be, what do you recommend that healthcare systems do to minimize the risks faced by nurses and other healthcare providers working on the front lines?
Yeah, I love this question because it calls into mind the dilemma that I was in that day. I felt I couldn't speak up when I had the sense that this patient had COVID. And when I did, my concern was dismissed. So we obviously need more robust measures to promote safety and support for our frontline workers. This could be a simple communication tool like an in-house provider hotline that we can call anytime we feel unsafe. This could be RTs, PTs, nurses, anytime we feel unsafe or have questions. And in fact, they recently installed a panic button on the unit anytime we feel physically threatened. So how great if we could also implement a COVID panic button. I would love to see that happen. But yeah, I mean, it's great that they put the banner outside the hospital, that heroes work here. I love that, but I also feel that more immediate, tangible support is needed, support that protects providers, their families, and the communities.
Thank you. You may receive some additional questions from the audience about your experience and additional recommendations. And we're so glad that you're here to tell your story and others can learn from it. I'd like to move next to Benjamin, who will also give you a brief background about when he graduated and his experiences as a nurse to begin with.
Hi, so I, as Soraya said, graduated in June of 2019 with my RN. Prior to that, I spent 10 years as an LVN and worked in various settings doing that. I worked in a hospital and then various residential settings, mainly in mental health and substance abuse. With my RN, I transitioned to the emergency department, working at UCLA Santa Monica, and I've been there for a year, working, a little over a year, working there.
So as a nurse employed in the emergency department, as I understand you are, you see COVID patients daily. Can you share your personal experiences caring for and interacting with these patients and their families?
Yeah, so we do see quite a few COVID patients daily in the emergency department. We probably started seeing patients with COVID-like symptoms as early as December. And then moving on from there, we started being able to test people end of February, beginning of March. UCLA came out with a test pretty quickly, which we were fortunate to have. And we shut down all visitation into the hospital in about, I think in March is when we did that, and carried that through until June, which was quite stressful for us and people's families, because we rely on families as a great source for history and support for patients. So it's been very anxiety provoking for everyone involved. And I think that we lose a lot of the human connection caring for these patients because we have to be completely gowned and gloved with face masks and face shields, and we're behind our PPE and we can't, it's hard to communicate between the mask and for patients to see our facial expression and to be able to really get a good human connection from us. But I think that being at UCLA, patients are feeling more and more safe because of the measures that we've put in place. We have the tent outside, we have a pretty robust screening system for people coming in. And then we do our best to isolate the patients as we can as they start to come in if we know that they have symptoms into the ED, and then being able to educate people on where they're being placed in the hospital in relation to other COVID patients has been really important. One of the hard things that we've been dealing with is the changing information that's been coming out about COVID, but it's stabilized in the last couple of months, and we're really fortunate for that. And I'm grateful for everyone that's been supportive of our efforts at UCLA.
So I understand that you were actively involved with the leadership of Broad Spectrum at UCLA when you were a student. Please tell us about this group and how your experiences as a student relate to your current work as a nurse who is aware of health disparities and discrimination faced by marginalized communities.
Yeah, so Broad Spectrum is a student organization within the School of Nursing for LGBTQAI individuals so that they can have a community and discuss topics within healthcare and feel safe within the School of Nursing. It's open to everyone that's part of the School of Nursing as a student. And I've carried that through to my practice, educating coworkers and re-educating myself as well, because the community is constantly changing, and we see a lot of individuals, especially in the LGBT community, who don't feel safe discussing their care with healthcare individuals because they feel like they're going to be discriminated against. They also don't feel safe accessing care because they're afraid that if they identify a certain way, that they'll receive care that is substandard to someone else. And it's our job as healthcare providers to make sure that we are making them feel safe in the health environment, that we're creating a safe space where they can discuss their health concerns and their lifestyle with us. It's been hard, especially with COVID, because a lot of them are a little bit nervous to tell us that their family member is, or their partner is of the same sex, and asking us to call them. And it's it's a hard conversation for them to have, especially in our trans community and our Black community. It's been very difficult for them to open up to us and have that discussion.
So you've sort of begun to the last question. We don't have much time on this, but any last minute recommendation for nurses who are interested in becoming advocates and allies to patients who experience health disparities for COVID and other conditions?
So I think that educating yourself and remaining open and having hard conversations with people around you first is helpful to be able to see how you're coming across and being able to translate that into your practice. The other tool that I use quite often and that I really ground my practice in is called trauma-informed care. It's a great model to be able to use with every patient that comes in and understand that every patient has a different experience and be open to that and help them explore that and feel safe within the healthcare environment. So I encourage everyone to have hard conversations, be open, challenge your cognitive distortions and beliefs about what's happening within your community, and then explore trauma-informed care, because I think it's a really important model that we can all use and translate that into our practice to help make our healthcare system better.
Thank you so much, Benjamin, for all your thoughts. And I think that you've made some very specific recommendations that others can benefit from learning about. Jamaris, we now are moving to you in terms of your brief background, when you graduated, experiences, and then I have some specific questions about your work at the Veterans Administration.
Yes, hello, and thank you so much for having me. I graduated in the MECN program as well in 2018. After that, I waited about 6 weeks to take my NCLEX, and then I moved on to the VA Medical Center. Prior to that, I was already working at the VA Medical Center. I was working as a kinesiotherapist. For those who don't know, it's like physical therapy, but we have different scopes. Anyway, I decided to pursue my career in nursing. Graduated and I entered the transition to practice program as well there at the VA Center. And I currently work on the Med-Surg telemetry unit. And it's a great experience. I didn't realize nursing had so many fields. I feel like we're counselors, we're dietitians, we are social workers, we're family to the patients, but it's such a humbling and great profession. And I wouldn't have chose any other profession.
So as a nurse recently employed in the Veterans Administration, we're interested in hearing about your experiences caring for and interacting with patients who have COVID-19 or other health disparities that increase their risk for this virus.
Yes, well, at the VA, we have come across a lot of patients with COVID. We've designated certain units for our COVID-19 patients. I actually had to work on the COVID unit for about 2 to 3 months. That was a very humbling experience. Fortunately, I was very proud of the VA because we had all of the PPE that we needed. We never ran out of PPE. I felt as though times it was a lot of waste of PPE. I can't admit, because we're constantly in and out the rooms, like the previous speaker said, with face masks, gowns, shields, everything. So I felt that at times, as soon as you come out the room, you have to come back in the room fully gowned. So that was a great experience, actually. The only thing I will say, I felt for the patients. I felt this time as though, they felt alone. They couldn't have visitors. Families couldn't visit them. So a lot of times we had to use our phones to communicate with the families. And the only time the family would be able to see that patient was at their end of life. So that was the only it was very heartbreaking for me to see that, you could tell that that when you look in their eyes or at their face, that they were just, terrified. And I felt as though there were times that I really couldn't help them. And that their families were also suffering as well because they weren't able to share their time with their loved ones.
How difficult that must have been for you.
Right.
In relation to your stories, I'm wondering if you saw any instances, or you directly or you heard from your colleagues about discrimination and disparities against any of these patients or patients who might have faced risk for COVID?
Fortunately, I didn't experience any of that within the veteran population. I did hear, a few of my colleagues said that, as far as their families experiencing it, but I haven't experienced it at the VA. anything like that. I have not personally, no.
So from what you heard from colleagues or your own thoughts about this, in an ideal health system, what strategies would you use to promote health equity among people experiencing health disparities?
Well, I would say just educating ourselves, educating other people as well, your families, your colleagues. It's all about educating ourselves and being aware of the disparities that are going on, and also along with the discrimination that's going on as well. If you educate yourself, I believe that they'll give you a better understanding on how to deal with these situations, and you'll have a better perspective of it as well.
Well, I'm glad to hear that you haven't encountered any direct experiences for your patients or yourself in terms of discrimination or different treatment.
Right, I haven't. I'm thankful to have said that. Me personally, no, I have not.
That's good. And sometimes just supporting our colleagues who may have is so important.
Correct.
Okay, thank you so much, Jamaris. And we're going to move on to Harold, who will tell us about his experiences at UCLA, the program he graduated from, and what he's doing now.
Hello, everyone. So, hi, I'm Harold. So, I graduated from UCLA from the Adult Gerontology Primary Care NP program back in 2016. So, I've been an NP for over 4 years. I started working as a nurse practitioner at AIDS Healthcare Foundation in Beverly Hills right after school. So, I was doing HIV primary care among underserved patients. I did that for about 2 years. And then I joined Kaiser Permanente here in Los Angeles early 2018. Here at Kaiser, I'm the person in charge of the PrEP program. I'm still in HIV medicine, but I'm doing a lot of prevention instead of treatment of HIV. I'm also doing a lot of treatment for STIs among our members here at Kaiser. But in general, I've been a nurse for almost 19 years now. I graduated in 2001. So I've been a nurse. I never had any other career than being in healthcare.
So in your area of specialty as a nurse practitioner is infectious disease. So you're managing a variety of patients with serious conditions, such as COVID, or those who might be at risk for COVID.
Yes.
The public and healthcare providers may respond differently to these patients. And you've probably seen this because you've done direct AIDS care. What have you witnessed or professionally experienced as an NP? And I'm going to combine things here. Any recommendations that you have for dealing with the kind of divisions you might have seen, those dividing us with discrimination?
Yeah, of course. So disclaimer though, I don't work directly with COVID-19 patients. I work in the HIV clinic, but our team in ID, we are being consulted for anti-infectives among our hospitalized patients, also for compassionate use of remdesivir for the inpatients. But what I notice though among my patients who have HIV or those who are at risk of contracting HIV, I've seen a lot of fear. There's a lot of anxieties among our members or our patients. Some of them they don't like going to the clinic to follow up, or some of them because part of their care they get their lab works done regularly. So instead of some of them refuse to go to the labs because they're scared of contracting the virus, being exposed out there in public. Being in charge of the PrEP program, I noticed a lot of my patients have stopped taking their pre-exposure prophylaxis medications because they're scared of contracting the virus. So there's a lot of fear, there's a lot of anxiety. Sometimes, when I talk to them on the phone, I feel like I'm not just being a provider, but I'm also being a therapist to them, trying to calm them down and help them deal with their anxieties.
Of nurse practitioners and other nurses must work directly together to address barriers and increase access to quality patient care in order to eliminate health disparities that increase individuals' community risk for COVID and other infectious diseases. Mm-hmm. So what are your recommendations here in terms of, I'm going to ask you to focus more now on the discrimination disparities with this pandemic or with perhaps the kinds of infectious diseases that you are dealing with?
Yeah, well, even before the pandemic, there's a lot of evidence that racial and ethnic minority tend to receive lower quality of care than non-minorities, right? So, especially my trans patients, my LGBTQ patients, not a lot of clinicians are trained to provide this population compassionate or sensitive care that they need. So I think my recommendation is training providers in providing them with the care that they need. And also in general, I work at Kaiser now, so I see patients with insurance. So in general, I think having a universal healthcare system here in the US, that way we're able to provide access care to all people despite of their ability to pay.
I think that's particularly important in terms of access to care. I think that we will have, based on the panel discussion and depending on the number of questions, we'll have time for us to revisit the issues of disparities and discrimination and ask questions of each other, or and perhaps share additional remarks that you haven't had time to say before during the actual panel discussion. So I'm going to move us along and thank the four panelists for sharing their experiences, their ideas, and some of their direct thoughts about care of patients with COVID and health disparities and discrimination. At this point, what I would like to do is move us to our Q&A and have questions presented by two of our moderators, who will take a few questions from the audience, and that is Dr. Anita Braylock, who will say hello to you in a moment.
Hello, everyone.
He is the Director of Diversity, Equity, and Inclusion in the School of Nursing, and she works along with Craig Kusunoki, who is the Assistant Director of DEI in the School of Nursing.
Thank you.
Hello, everybody.
So we're going to start off with a few questions from our Q&A, and I encourage people to start typing in your questions because we still do have a few more minutes for our question and answer period. We did receive a question from someone that has been answered by one of our panelists, but I would like to read this question to give our other panelists an opportunity to still answer this question. And those of you who want to type in a question into our Q&A, you still have time to do that. So the question is, what do you recommend to keep students safe in our nursing labs? We just basically admitted our brand new students into our fall cohort, which just started on October 1. And we have nursing students that are going to be going into the UCLA Medical Center, as well as the VA. We have students that rotate to the into the VA. So the students are very excited to be able to go into the hospitals for the hands-on experiences. But I remember during springtime when COVID first started, students were very scared to go into the hospitals for fear that they might combat the COVID virus. And so the question is, what do you think, the students can do to basically protect themselves when they come into the hospital settings? Jamaris, not to put you on the spot, but have you seen nursing students in the VA? Are they only on certain units and not on other units?
Yes, I have been fortunate enough. I'm so excited when I see my MECN students. Yes, we have had MECN students now. We don't allow the nursing students to go to the COVID unit, of course. But yes, they are on our general floors. But I just try to educate the students. I always, remind them to, definitely wash their hands. I also make sure that they check the patient's chart, because even though we have a designated COVID unit, we still have COVID positive patients on med-surg telemetry. They consider them non-contagious, like our other speaker was saying, sorry, I forgot his name, but new guidelines come out, it seems like every week or every 2 weeks. But I still tell them to, treat that patient I mean, unfortunately, like a COVID patient, I mean, still wear your mask, your shield, you know, gown up, glove up. When I have to do tests, I don't allow the students to come into the room with me to do the test unless they just absolutely want to. And like you said, they are eager to learn, but I don't really want to expose them to that, but they are more than likely welcome to come in there. But I just always tell them to just be aware, you know, hand hygiene, and like I said, full body gear, you know. And for patients that aren't COVID positive, I believe this is in every hospital anyway, you still have to wear your mask. And if you want to wear your shield as well, just to go into a patient's room, you're more than likely to do that as well. So
You're welcome. Okay, thank you. Soraya, would you like to answer that question, the same question about how could you help with nursing students who might have the fear when it's their med-surg A that they'll be taking in wintertime in January with the flu season and everything that's going to be happening in January. You will be seeing beginning students at your particular hospital. What do you think, or what words of wisdom could you give? Soraya?
Got it. Mine is a much shorter answer. I just feel that nursing students are the most, what's the word? They're better at practicing hand hygiene. They're much more efficient. They're much more diligent. And I'll be very honest, during my preceptorship, I've seen people be really sloppy. And I know I'm not alone in that. So I think like, just keep it serious, keep going, keep doing what you're doing. Everything that Benjamin laid out is exactly spot on. We need to not get sloppy and lazy just because we've become nurses, and really just instill that in the nursing students.
Okay. Craig, would you like to read the question for Harold?
Yeah, Harold, this question is directed to you. This is from a current student. Do you have any resources or information that we, as future nurses, can utilize to learn how to provide competent care for LGBTQIA patients?
Okay. Well, here I work at Kaiser though. So here at Kaiser, we have a team of we call ourselves LGBTQ champion. But there's a lot of resources out there. I know UCLA at the Gay and Lesbian Resource Center, they also can provide training for students there. Also UCSF, they do have a great training tool if you go on their website for LGBTQ and especially for transgender patients. But I think it's supposed, I didn't experience it during my NP program at UCLA, but I think it should be part of the nursing curriculum, whether you're in undergrad, master's, or doctorate program.
Okay, I have a question, and this question states, are hospitals allowing families to visit the COVID patients now? I remember back in March, April, they weren't allowing, like Ben talked about, when everything was shut down and didn't reopen until June. So are they allowing patients to be visited by their families? And can you let us know which hospitals are doing that, if any? So I guess this person wants to know about family members being able to visit COVID patients.
at the VA, I will say they are able to visit the COVID patients now as of about 3 weeks ago, 3 or 4 weeks ago.
Oh, that was still not that long ago, right? Yeah, 3 or 4 weeks. So it's been almost 6 months before they were actually allowing family members to come in and visit?
Yes, and they have certain restrictions, only 2 people at a time. You can only stay for 2 hours. You can't come and go. So once you leave, you're gone for the day. You can't come back, but yes. Mm-hmm.
Okay, all right. Anyone else want to answer that?
So here at Kaiser, oh, sorry, go ahead. Go ahead.
No, go ahead, Harold.
So here at Kaiser, they're also limiting visitors in the ICU. So no visitors right now at the in the ICU. But in other floors like med-surg or tele, I know they're allowing visitors, 1 visitor at a time on certain hours. Unlike pre-COVID, visitors can visit anytime, but now there's only a window period where visitors can visit. Go ahead, Benjamin.
Yeah, so at UCLA, we are not allowing patients with COVID symptoms or who have tested positive for COVID to have family members at this time unless they're end of life. If they are end of life, they're making special arrangements for them. Our visitor policy is a little bit more lax in the emergency department right now. because it is very important that we have family members in there with them. They all have to be masked and temperature screened and everything else, and they have to maintain 6 feet of social distancing from any other patient. But up in the hospital, we still have a pretty strict visitor policy, 1 visitor per patient per day, and they have to be symptom free, and the patient has to test negative for COVID.
That's
Okay.
the same at St. John's.
Okay. Thank you.
Allison.
Craig, did you want to read the anonymous attendee question?
Yeah, here's a question that is open to any of the panelists. What lessons from your time at the UCLA School of Nursing have been most helpful to you in this time?
Who would like to start that one?
I can start on that. So I think it's really important that you understand pathophysiology and how that affects everything that you do in your practice, and really have a strong foundation in pharmacology as well, because we're seeing so many new medications that we're going to be testing, especially if you're going to work somewhere like UCLA, where we are an academic institution. So I would say both of those things. Another thing that I found that I think about every day is a lot of our classes in ethics and dealing with vulnerable populations, and then public health. Public health is probably the most important class that I took while I was at UCLA, and I can't tell you how invaluable that experience was for me. And understanding what resources are available for patients who are in vulnerable situations. So I think that that's probably what I took away from UCLA right now.
So can I just ask one thing related to what you're saying now, to build upon what you're saying in terms of what happened after you've been to UCLA and relating it to your employment setting where you are now or where you may have been in the past? How are you seeing strategies that, like, for example, implicit bias training or other types of in-service education that might really address the disparities and discrimination that connected to them, including some of the remarks that Kia said? Because we'd be really interested in hearing more about that if possible.
Yeah, so I think that UCLA is working very hard to educate everyone on racial disparities and disparities within the healthcare system. They do have a lot of modules on Cornerstone, their education platform, that we can sign up for whenever we want. They do encourage us to do it. They assign them as needed. We do practice something called CI Care, that we're supposed to implement for every patient, and it's supposed to make patients feel comfortable and heard. As far as implicit bias, I think that we are getting there at UCLA. I know that they've been asking us to participate in a lot of research about implicit bias in healthcare workers. So they've been encouraging us to do that through work. And I know that I did one for one of the PhD students at UCLA as well. So I'm hopeful that we'll start doing more about implicit bias, because I think it's really helpful to recognize what your bias is, even though we think we're mindful, we're not always mindful of that.
I have another question, and this one is for Harold. I'll try to say this quickly, Harold. It's a long question, but I think it could be a fairly shorter answer. This person is basically saying that, you know, for a while, the influx of patients have decreased for a couple of months, right? And partly due to people fearing going to the hospitals and actually contracting COVID. So Harold, have you seen an increase in patients needing medical care within the last or the past couple of months since we've had more acceptable guidelines to care regarding COVID? And if so, have you seen a stable or worsening of patients' chronic diseases and symptoms due to not getting the proper care during the early months of the pandemic? So during the early months, people actually stopped going to the hospitals because they thought they would get COVID. And now with the guidelines, people are feeling more comfortable going back into the hospitals. And how has that affected the types of patients you've seen?
So like what I said, I have limitations seeing this kind of patients though, because I work in HIV clinic. So I see a specific kind of patients, but based on reports, based on my colleagues here at Kaiser. So, you know, patients who are having heart attack, they're not being reported, or some of them are dying at home because they don't want to go to emergency room because they're scared of contracting the virus. I oversee our infusion centers. So cancer, I deal with cancer patients as well. So with these patients during the first 3 months of the pandemic, some of them are deferring their treatment, their chemo. But lately, maybe in the last 2-3 months, some of them are coming back. And then like what you said, you know, with other issues, not only their cancer, but their other medical conditions are not being managed properly because they delayed the care during the initial phase of the pandemic. But yeah, I mean, it's there. It just, I don't work with them directly because I don't work in ED or I don't work in primary care. But based on our patients, based on reports from my colleagues here, it's happening. And also based on studies.
Anita or Craig, if you don't have any additional questions, I would like to maybe add one thought because—
Well, we do have additional questions actually.
Okay.
Craig, would you like to go through the next one?
Yeah, and I think we only have time for maybe one more question and answer. So we'll go with this one, open to any panelist. How did you get over your anxiety over taking care of patients who have COVID and to avoid burnout?
I have an answer. I found that working with the MARC program at UCLA and their mindfulness, MARC is an acronym and I cannot remember what it stands for, but it's MARC, and it's been such a valuable resource for me. Practicing mindfulness, we learned all about this with Barbara Demon's class. And it's just been such a great tool for me and for my family because it is scary and it is the thing that's shut the world down. And I think just practicing some mindfulness and meditation is super helpful. Also therapy. I did 10 sessions of therapy that was offered to me through the hospital, and I felt that very useful. And another useful thing was just jumping back in and not being afraid. So much anticipation just stifled me. And once I just got back in, learned how to put on the PAPR, learn how to just walk into a patient's room, like you really connect at that level, like human to human when you're back in the room.
Yes, and like Soraya said, it definitely is scary. But you know, we were put in this profession to help others. We're at the front line. Nurses are a very important part of patients' care. And prayer also helped for me as well.
Anyone else want to respond to that anxiety?
I think understanding what PPE is available to you and what PPE protects you really helps. And then as far as reducing burnout, I think it's just really important to be honest with yourself and with those around you about what you need. Sometimes if you can't have a day where you're constantly gowning up and masking up, really be honest with your charge nurse and tell them, hey, if I can get a lighter assignment today because I'm feeling burnt out with this, let's make that happen. And I think that people have been really receptive right now, listening to our needs and what would be best for our patients.
Okay, thank you very much.
So we have another moment. And before I do closing, I would love to see if Kia is with us. If you have seen or know about any delays in diagnosis among diverse groups for COVID, what type of recommendations you might make to nurses so that they can get the care that they need in a timely fashion. And if anybody can answer this, but I thought, but we cut you so short on your introductory remarks, you might have more to say on this.
What can nurses do to get people more timely diagnoses. Is that your question?
Among diverse populations, if there's delay, particularly among marginalized populations, what we can do to make it safer and help them to come in earlier so they're not as sick, and we can perhaps change the morbidity and mortality.
Well, I think a big problem initially was a lot of misinformation. And as health educators, just a lot of our work is patient education. So getting out actual facts about transmission, about protecting oneself, about what social distance or physical distancing looks like. It's not necessarily being held up in a house or an apartment for 6 months, because that's unhealthy too, but it's really educating people on how to protect themselves, but also maintain their own mental well-being at the same time.
Okay. Thank you so much. In terms of, I think we've shared a lot of information about your careers and your experience with COVID, and some in terms of the experiences with discrimination and disparities. It was nice to hear that you haven't directly seen the discrimination in the workplace so far, but we know that you have, by the very patient population that you may be serving, evidence the results of health disparities. So I hope that we will continue the discourse with other events in the future. And I thank the alumni for participating in this forum of discussion and opening it up, and having our students and some of our other colleagues attend who benefited from hearing you. I'd like to ask you, before you sign off, to complete that very brief survey that will help us. And thank you, Kia. Thank you to all of our panelists. Thank you, Craig. And thank you, Anita, and for the team from development for all of your support in making this happen tonight.
Thank you for having me.
Thank you.